Greetings of the day. In this talk, I will be discussing about differences between adult and pediatric chronic myeloid leukemia. I am Dr. Deepam Pushpam. I am working as faculty in Department of Medical Oncology at All India Institute of Medical Sciences, New Delhi. The talk is divided into the heading biology, clinical features, management, treatment-free remission, and advanced chronic myeloid leukemia management. And I will be focusing on the important differences between pediatric and adult CML. Coming to the biology, in BCR-ABL fusion sites of pediatric CML has got a bimodal distribution. As we can see in the left side of the figure that there are two peaks, and this bimodal distribution is similar to BCR-ABL positive ALL. However, in adult CML, there is a single breakpoint cluster within the first centrometric 1.5 kilobyte of the BCR breakpoint cluster region. As we can see on the right side of the figure that there is only one peak. There have been studies which have tried to evaluate the mutation and transcriptomic signatures and compare the differences between pediatric CML and adult CML. ASXL1 mutations are more frequent in pediatric CML when compared with adult CML. Gene deregulations in PI3K, AKT, WNT, beta-catenin, sonic hedgehog, and MAPK kinase pathways are more frequent in pediatric CML. There has been a study where transcriptomic signatures of pediatric and adult CML CD34 cells were performed by high throughput RNA sequencing analysis. And they found that a lot of genes were differentially expressed between pediatric and adult CML. And the key pathway that was downregulated in pediatric CML CD34 cells was the Rho pathway. And it is thought that Rho pathways might be one of the unique molecular pathway which may have a role in pediatric CML pathogenesis. In the left side, we can see the funnel plots showing the genes which are upregulated in pediatric CML, and in the left side and on the right side, we can see the genes which are down regulated in pediatric CML when compared with the adult CML. And as we said earlier, in the right figure, we can see that Rho GTPase pathways are the key pathways which are down regulated in pediatric CML. Coming to clinical features of pediatric CML, in comparison to adult CML, pediatric CML patients have higher WBC count, larger spleen, higher peripheral blast counts, lower hemoglobin, and they have frequent accelerated phase and blast phase diagnosis in terms of percentage when compared to the adult CML. And they also have less favorable cytogenetic and molecular response. However, it is pertinent to note that despite having high unfavorable characteristics in pediatric CML, there is no difference in overall survival when pediatric CML patients are compared with adult patients. Coming to role of prognostic scores in pediatric CML patients. So we do not have a standard pediatric CML specific score, and in adult scores we use SOCAL, Hasford, and IOTUS. These three scores they do not correlate with early outcome in pediatric patients. However, a study from India had shown that IOTUS long-term survival score correlates with progression-free survival. But at this point, we need a large number of patients and longer follow-up is required for development of pediatric CML specific prognostic score. Another interesting point to note is that in adults, additional cytogenetic abnormality is associated with inferior outcomes. However, this might not be the case with pediatric CML patients. Impact of imatinib dose on outcome. So in imatinib, different doses have been used in pediatric CML patients. At imatinib dosing of 260 mg meter square, which is adult equivalent of 400 mg per day, BCR ABL international score less than 10% at 3 months. Patients who achieved this had higher cytogenetic molecular responses and better progression-free survival. But if we increase the dose of imatinib to 340 mg meter square, adult 600 mg per day, and we use a BCR ABL 10% cutoff. So at this dose, it does not predict the outcome as 80% of patients achieved early response. So in pediatric CML patient, dose of imatinib influences response and outcome apart from the prognostic scores. Treatment of choice and dose of imatinib. In adults, we have clarity that imatinib is better in safety and second generation TKIs have a better response. However, at present, data is lacking regarding second generation TKI superiority and regarding the long-term side effects of second generation TKI. So dose that have been used in studies has ranged from 260 to 340 mg meter square. At our center, we use dose of 340 mg meter square. Another issue with pediatric CML patient is that under 4 years of age, it is difficult to define the optimal dose due to pharmacokinetics which are different in this age group of population. And usually imatinib is administered as liquid formation or tablets dissolved in water or apple juice for patients who have difficulty swallowing. Coming to the monitoring of children on TKI, bone marrow is done 6 monthly till complete cytogenetic response is achieved, and at molecular monitoring from peripheral blood for RT-PCR is done every 3 monthly till patient is under follow-up. However, it has to be noted that there is lack of pediatric specific response criteria, and at present adult guidelines are extrapolated for use in pediatric population. However, it is important to note that the children may attain late response when we follow adult criteria. So if a child has a suboptimal molecular response, we can observe for another 3 months before switching to second generation TKI. And meanwhile, we are waiting for the response by extending the first generation TKI. We have to evaluate for adherence, BCR-ABL mutation analysis, cytogenetics, and BCR-ABL1 transcript ratio in bone marrow also needs to be evaluated. Coming to the distinct side effect of TKI in children. So, as children are a growing population, so that in this group of patients, we have to be careful regarding the side effects of first generation as well as second generation TKI. So there are studies which show that imatinib causes growth deceleration primarily in prepubertal children. However, during puberty, most of the patients they have a catch-up growth, and this phenomena has also been reported with second generation TKI also. And there is a studies which suggest that there is decreased bone mineral density and alteration in vitamin D, calcium, and phosphate metabolism. Dasatinib-induced pleural effusion is common in adults. In Dasasion trial, approximately 28%, that is 1/3 of the patients had pleural effusion, and 6% of the patient had to discontinue the drug. This adverse effect is less common in pediatrics, as only around 6% had reported pleural effusion, and these pleural effusion were in grade 1 and grade 2 only. Long-term adverse effect of hypertension, pleural effusion, and pericardial effusion have been reported in small study with dasatinib. Treatment-free remission is standard of care in eligible adult patients. We have some data which shows that this approach is feasible in pediatric patients. In a Japanese prospective study of 22 patients who were on TKI duration for 2 years and sustained molecular response of more than 2 years, treatment-free remission at 12 months was 50%. And 11 patients had lost MMR within first 4 months, and they regained major molecular response after TKI initiation. None of the patients suffered from withdrawal syndrome. So these results are similar to adults, where treatment-free remission has ranged from 52 to 61% in various studies. So this study shows that treatment-free remission is a feasible concept in pediatric patients, and this approach has the potential to avoid long-term TKI toxicity. The other approach which is interesting and is under development is if we can achieve early treatment-free remission by using second-generation TKIs. So in adults, we have ample data to show that second-generation TKIs have faster and deeper molecular remission. However, in pediatric CML, we do not have randomized controlled trial. Limited data from pediatric CML cohorts suggest that molecular responses at 6 and 12 months are deeper with second generation TKI, but they are similar to imatinib at 18 months. So second generation TKI may be a good option for first-line therapy in children, where treatment-free remission is the goal to avoid long-term toxicities. In pediatric CML patients who are resistant or intolerant to TKI. So for this subgroup of patients, at present, the approved TKIs are imatinib, dasatinib, and nilotinib. So we can switch to second generation TKI, that is dasatinib or nilotinib, the patient is on imatinib. For ponatinib also, we have encouraging data, and in a heavily pre-treated patients, 50% patients achieved major molecular response after initiation of ponatinib. The side effects of ponatinib in children were mainly hematologic and pleural pericardial effusion. Vascular toxicities, which is common in adults and is one of the life-threatening adverse events of ponatinib, did not occur in children. Allogenic hematopoietic stem cell transplant remains preferred approach for patients who are failing 2 lines of tyrosine kinase inhibitor or T3I5I mutation, and this treatment approach in this group of patients is similar to adults. Coming to role of hematopoietic stem cell transplant in CML patients in chronic phase, it is debatable. The pros of going for an hematogenetic stem cell transplant is that it will avoid long-term TKI toxicities, and with the current advancements in transplant, and the outcomes are favorable with more than 90% survival. However, the drawbacks are that there are chances of early morbidity and mortality. So, and we also have second generation TKIs available. So currently first generation TKIs are failing, then we go for second generation TKIs, and at present upfront transplant in CML CP is not advocated by major group of experts. The current indications of transplant in CML are advanced phase chronic myeloid leukemia, progression to CML accelerated phase or blast crisis, resistance to second generation TKI, T315I mutations. Coming to advanced pediatric CML, data is limited. Treatment suggested are combination of tyrosine kinase inhibitor with or without chemotherapy. Dasatinib is the preferred TKI in this setting. And in pediatric CML, 5-year overall survival of 94% has been reported in accelerated phase and around 74% in blast crisis. This survival is better than adults, where 5-year overall survival has been reported to 38% in accelerated phase and 57% in blast crisis. And outcome in pediatric patients appears to be favorable even without hematopoietic stem cell transplantation. So consensus recommendation suggests that we should use linear specific chemotherapy plus TKI in advanced pediatric CML followed by hematopoietic stem cell transplant. To conclude, there are key clinico-biological differences between pediatric and adult CML. We need to specially give consideration for growth, endocrinological dysfunction, and long-term TKI adverse effect. And treatment-free remission approach should be used wherever it is feasible. And it is imperative that pediatric CML is managed by pediatric hematologist and oncologist using pediatric specific guidelines. Thank you.